Yes, I will introduce myself. Uh, I'm visiting here from Emory. Thank you very much for the invitation. This is the aortic session, and we were chatting a little bit before about the role of vascular surgeons versus cardiac surgeons in treating proximal aortic pathology. And I look at the aorta as one organ, and I think vascular surgeons are important in managing all conditions of the aorta. Uh, I do have some financial disclosures, all related to research support to my institution, but importantly, I will be discussing an off-label use of some endovascular devices. Bental procedure is an open aortic procedure first described in the 1960s by Dr. Bental in the United Kingdom. It involves surgical replacement of the ascending aorta, aortic root with reimplantation of the coronary arteries, and also replacement of the aortic valve. It's performed for all pathologies of the aortic root, whether dissections, acute and chronic, or aneurysmal degeneration. Like everything else we've experienced in the last 20 years, the question always arises if there is a role for endovascular devices in treatment of the aortic root pathologies. We do have an endovascular treatment for an aortic valve pathologies with PAVSS. We have stent grafts for all aortic aneurysms and dissection pathologies. And we do have an emerging technologies for branched and penetrated devices. So the question is if we can deploy those techniques in treatment of the aortic root. If you look at the aortic root and the ascending aorta and the annulus, you can imagine that there are many obstacles to endovascular treatment of this problem. The proximal landing zone, if you are going to put a stent graft in it to use it for deployment of an aortic valve, has to measure less than 30 millimeters in diameter to be suitable for the existing endovascular aortic valves. You do have limitations in the amount of length that you can use at the aortic sinus and the LVOT, the left ventricular outflow tract, as extending the length of the proximal sealing zone there can affect the mitral valve as well. Of course, the length of the ascending aorta impacts your ability to use stent grafts of varying lengths, and that length is usually short, somewhere around 8 centimeters. The coronary artery diameter for use with covered stents is a limitation. 5 to 6 millimeters is usually, from our knowledge with renal artery treatment with penetrated and branched endografts, is usually a small diameter for patency of the covered stents. The length of the left ventricle to accommodate a nose cone of an aortic device or an aortic valve is an important consideration, as you don't want ventricular perforation if you are using other than an apical approach for deployment of the stent graft. And of course, as you deploy any device through the aortic valve, you can have severe aortic insufficiency, and you have to always be ready to utilize some sort of cardiopulmonary circulatory support. Now, an endovascular Bental procedure has been described at least twice in the published literature so far. None of them was from the United States. One was from Brazil, and there's another paper currently in publication from Germany. This is the first paper. It's the first in-human endobental procedure. This involved a 64-year-old patient who presented with bleeding from the neck. She had an aortic valve replacement prior to that, and her CT angiogram showed a pseudoaneurysm originating from the prior arteriotomy, and her CT scan showed significant calcifications, and she was evaluated by the surgical team, by the authors here, and found not to be a suitable candidate for open repair, and therefore she was considered for endovascular Bental procedure. And this is the device that they used. It was a customized manufactured device with a valve, a balloon expandable valve in its proximal aspect, a tapered device to allow maneuverability of the coronary stents, and the dilated portion more distally in the distal ascending aorta. So this was the device that was used, and they reported good success with good survival for that one patient. Now again, there's another paper that was in print, and I'm not quoting it here. It was a physician modified endograft with no coronary stenting, but just a stent graft with an aortic valve deployed in. Now, our case, as far as I know, is probably the third in the world. This is a new case submitted for publication. This is the first time where it gets presented. This is our technique in Emory that we utilized. As opposed to the prior two cases, we did not use a cardiac approach. We used a transcarotid and a transaxillary approach for this device. This was a 71-year-old gentleman who had cardiogenic shock and was hospitalized for a total of 8 weeks prior to us considering this approach for him. He's had worsening cardiac failure with acute renal failure with the new onset of hemodialysis. His past medical history is extensive, as shown here, with chronic kidney disease, atrial fibrillation, diabetes, hypertension, and had metastatic prostate cancer. He had a prior aortic valve replacement, and due to his multiple comorbidities, he was not considered to be a candidate for open approach, and he failed medical therapy, and therefore we had to consider endovascular approach. Now, we've thought about this approach multiple times before in multiple patients, but due to the lack of devices, we thought that this was, we never really tried it before. So this was the first patient that we did this device, use this technique on. Now, there are CT scans, but I figured that the echocardiogram shows the problem better. You can see the left atrium, LA, left ventricle, LV, and the aortic, the proximal ascending aorta. This patient had a fistula from a large fistula from the left atrium to the ascending aorta, resulting in this worsening cardiogenic shock. You can see it by video here, a large fistula from the LA to the ascending aorta. So the technique involved using a thoracic endograft with 2 fenestrations customized for the coronaries, covered stents for the coronary arteries, and a off-the-shelf Sapien aortic valve. We used rapid pacing and transcarotid delivery of the device. We did the device under peripheral VA ECMO. This video should summarize the procedure. We started by cannulating the coronaries. The device was deployed constrained in the aortic valve with rapid pacing under VA ECMO. We cannulated the 2 coronary arteries, placed sheaths in them, deployed the aortic valve, and then released the entire graft by ballooning it. Then deployed these 2 stent grafts in the coronary arteries. And this is the result. Weaned off VA ECMO, did okay for an hour, and then developed right heart failure. I was unable to interrogate the problem clearly intraoperatively, so I had to place the patient back on VA ECMO and took him to a CT scan. This showed migration of the stent in the right coronary artery into the sinus of Valsalva away from this fenestrated stent graft. So this allowed us to diagnose the condition, and we went back in and I extended that stent back into the ascending aorta with good results by CT scan and by echocardiogram as well, with resolution of the fistula. Patient stayed in the hospital for around 30 days and was discharged alive. All right. Well, in conclusion, this is an evolving reality. I think we will have to think about options to treat this condition in the future in a minimally invasive way. There are no ideal devices yet. We still will need to consider how a valve can be mounted on such a device and how circulatory support should be utilized, preferably by utilization of peripheral VA ECMO. Thank you very much.